Welcome to Pediatric Case Review. In today's lecture, we will explore Erb's palsy in children, a brachial plexus injury commonly seen in newborns. By the end of this session, you'll be able to identify key clinical features, perform appropriate examinations, understand pathophysiology, select proper investigations, and implement evidence-based treatment approaches. Let's begin this journey together. A one-day-old newborn presents with the right arm held adducted and internally rotated against the body. The arm shows decreased spontaneous movement compared to the left side. Birth history reveals shoulder dystocia during vaginal delivery. What is the most likely diagnosis? A. Clavicular fracture. B. Erb's palsy. C. Klump's palsy. D. Septic arthritis. The correct answer is B. Erb's palsy. This condition typically presents with the characteristic waiter's tip position where the arm is adducted and internally rotated, with the elbow extended and wrist flexed. This posture reflects injury to the upper roots of the brachial plexus, specifically C5 and C6 nerve roots. Shoulder dystocia during delivery is a significant risk factor for this condition, as excessive lateral traction on the head can stretch these delicate nerve roots. An obstetrician is consulting you about a high-risk delivery. The mother is 38 weeks pregnant with suspected fetal macrosomia. Which of the following factors presents the highest risk for Erb's palsy in the newborn? A. Maternal gestational diabetes. B. Breech presentation. C. Maternal age greater than 35 years. D. Previous cesarean delivery. The correct answer is A. Maternal gestational diabetes. Gestational diabetes significantly increases the risk of fetal macrosomia, which in turn raises the likelihood of shoulder dystocia during delivery, a direct cause of brachial plexus injuries. Additional risk factors include prolonged second stage of labor, instrumented deliveries with vacuum or forceps, and excessive traction during delivery. Breech presentation can also increase risk, but less commonly than diabetic macrosomia. A 2-day-old infant with suspected Erb's palsy is brought for examination. Which of the following tests is most appropriate to specifically evaluate biceps muscle function in this infant? A. Cookie test. B. Moro reflex. C. Bicycle test. D. Asymmetric tonic neck reflex. The correct answer is B. Moro reflex. When eliciting the Moro reflex, an asymmetric response with decreased abduction and external rotation of the affected arm indicates upper brachial plexus injury. This test helps evaluate function of muscles innervated by C5 and C6, including the biceps. The cookie test is used later to assess shoulder external rotation. Examining primitive reflexes like Moro is essential in early detection of brachial plexus injuries in newborns. A 1-week-old infant has confirmed Erb's palsy affecting the right arm. On examination, which of the following muscle functions is most likely to be preserved in this infant? A. Biceps. B. Deltoid. C. Intrinsic hand muscles. D. Infraspinatus. The correct answer is C. Intrinsic hand muscles. In classic Erb's palsy, the injury affects the upper brachial plexus, specifically C5 and C6 nerve roots. The intrinsic hand muscles are primarily innervated by T1, which is typically spared in Erb's palsy. This preservation of hand function is an important distinguishing feature from total brachial plexus injuries. The biceps, deltoid, and infraspinatus are all affected in Erb's palsy as they receive innervation from the upper roots. During a case discussion about a newborn with Erb's palsy, the team is reviewing different grades of nerve injury. Which of the following best characterizes neuropraxia in the context of brachial plexus injuries? A. Complete nerve transection. B. Temporary conduction block. C. Nerve root avulsion. D. Nerve rupture with scar formation. The correct answer is B. Temporary conduction block. Neuropraxia represents the mildest form of nerve injury, involving temporary disruption of nerve conduction while preserving the axon itself. This type has the best prognosis, with typical recovery within 3 months. More severe injuries include axonotmesis, where the axon is damaged but supporting structures remain intact, and neurotmesis, where complete nerve disruption occurs. Understanding these classifications helps predict recovery potential and guides treatment decisions. A 2-month-old infant diagnosed with Erb's palsy at birth shows no clinical improvement despite physical therapy. What is the most appropriate next investigation to evaluate this infant's condition? A. X-ray of the affected arm. B. MRI of cervical spine and brachial plexus. C. Nerve conduction studies. D. Muscle biopsy. The correct answer is B. MRI of cervical spine and brachial plexus. In cases without improvement by 2 to 3 months, imaging is indicated to assess for root avulsions or other structural abnormalities that might require surgical intervention. MRI provides detailed visualization of the nerve roots and plexus anatomy. Nerve conduction studies and electromyography are also valuable, but are typically more useful after 3 to 6 months to evaluate denervation. X-rays have limited value except to rule out associated fractures of the clavicle or humerus. A 4-month-old infant with persistent Erb's palsy is being evaluated for potential surgical intervention. When is the most appropriate time to perform electromyography to accurately assess denervation and prognosis? A. At birth. B. At 2 weeks of age. C. At 3 to 4 months of age. D. At 1 year of age. The correct answer is C. At 3 to 4 months of age. This timing is optimal because it allows sufficient time for Wallerian degeneration to occur and denervation potentials to develop, providing more accurate prognostic information. EMG studies performed too early may miss significant denervation, while waiting too long delays potential surgical intervention. These studies help identify candidates for nerve repair or transfer procedures, especially in cases showing inadequate spontaneous recovery by 3 to 6 months of age. A newborn is diagnosed with Erb's palsy following a difficult delivery with shoulder dystocia. What is the most appropriate initial management approach for this infant? A. Immediate surgical exploration. B. Passive range of motion exercises. C. Immobilization for 3 weeks. D. Botulinum toxin injections. The correct answer is B. Passive range of motion exercises. The cornerstone of initial management for Erb's palsy is gentle physical therapy to maintain joint mobility and prevent contractures while waiting for spontaneous nerve recovery. This should begin within the first week of life. Positioning and splinting may complement therapy. Immobilization is contraindicated as it leads to joint stiffness and muscle atrophy. Surgical interventions are reserved for cases without improvement by 3 to 6 months, and botulinum toxin has limited role in early management. A 6-month-old infant with Erb's palsy shows no recovery of biceps function despite consistent physical therapy. The latest MRI shows possible root avulsion at C5. What is the most appropriate recommendation at this time? A. Continue physical therapy for 6 more months. B. Nerve reconstruction surgery. C. Tendon transfer procedure. D. Botulinum toxin therapy. The correct answer is B. Nerve reconstruction surgery. The absence of biceps recovery by 6 months with evidence of root avulsion is a strong indication for surgical intervention. Nerve reconstruction options include nerve grafting for ruptures and nerve transfers for avulsions. The ideal window for primary nerve surgery is between 3 and 9 months of age, as delays beyond this period reduce potential for recovery. Tendon transfers are typically reserved for older children with established deficits who have missed the window for nerve reconstruction. A 3-year-old child with a history of Erb's palsy treated conservatively presents for follow-up. Which of the following represents the most common long-term complication that should be monitored in this patient? A. Complete paralysis of the affected arm. B. Shoulder joint contractures and glenohumeral dysplasia. C. Chronic neuropathic pain. D. Compensatory scoliosis. The correct answer is B. Shoulder joint contractures and glenohumeral dysplasia. Muscle imbalance between internal and external rotators leads to progressive glenohumeral joint deformity in many untreated or undertreated cases. This can result in posterior shoulder subluxation and joint dysplasia. Regular monitoring with physical examination and occasional imaging is essential for early detection. Other complications include limb length discrepancy, muscle atrophy, and functional limitations. Complete paralysis is uncommon as most children achieve some degree of recovery. A newborn with Erb's palsy following a difficult delivery also presents with respiratory distress. Which of the following associated conditions is most important to rule out in this scenario? A. Clavicular fracture. B. Phrenic nerve injury. C. Spinal cord injury. D. Rib fractures. The correct answer is B. Phrenic nerve injury. The phrenic nerve arises from C3 to C5 roots and innervates the diaphragm. Injury to these cervical roots can result in hemidiaphragm paralysis, causing respiratory distress in the newborn. This is a serious associated condition requiring immediate attention, including possible ventilatory support. Other important associated conditions include Horner's syndrome, clavicular fractures, humeral fractures, and cervical spinal cord injuries, which may occur during the same traumatic delivery. Parents of a 2-month-old infant with Erb's palsy are asking about their child's chances for complete recovery. Which of the following factors is the strongest predictor of favorable long-term outcome in this infant? A. Normal birth weight. B. Female gender. C. Biceps recovery by 3 months. D. Delivery via cesarean section. The correct answer is C. Biceps recovery by 3 months. The return of biceps function by 3 months of age is widely recognized as the most reliable predictor of favorable outcome in brachial plexus injuries. Approximately 70 to 90% of Erb's palsy cases show spontaneous recovery, with most improvement occurring within the first 6 months of life. The absence of biceps function at 3 months suggests a more severe injury that may require surgical intervention. Other factors like injury severity, type of lesion, and completeness of the palsy also influence prognosis. An obstetrician is requesting your input on preventing brachial plexus injuries during deliveries. Which of the following represents the most evidence-based strategy for reducing the incidence of Erb's palsy? A. Elective cesarean section for all suspected macrosomia. B. Training in shoulder dystocia maneuvers. C. Routine induction at 39 weeks. D. Avoiding maternal pushing efforts. The correct answer is B. Training in shoulder dystocia maneuvers. Proper training and techniques, such as the McRoberts maneuver, suprapubic pressure, and other established protocols for managing shoulder dystocia, is the most effective strategy for reducing brachial plexus injuries. While elective cesarean section may prevent some cases, it is not recommended for all suspected macrosomia due to limitations in accurately predicting birth weight and the increased maternal risks. Most importantly, approximately 50% of brachial plexus injuries occur in deliveries with no risk factors or shoulder dystocia. A 5-year-old child with residual Erb's palsy has plateaued in functional improvement despite consistent therapy. The child has reasonable shoulder movement, but limited elbow flexion and supination. What is the most appropriate long-term management approach for this child? A. Discharge from follow-up. B. Annual multidisciplinary assessment. C. Repeat MRI every 6 months. D. Secondary nerve reconstruction. The correct answer is B. Annual multidisciplinary assessment. Children with residual deficits benefit from continued monitoring by a team, including a pediatric neurologist, orthopedic surgeon, and occupational therapist. At this age, secondary procedures like tendon transfers or osteotomies may be considered to improve function rather than nerve reconstruction. The assessment should also address developmental needs, school accommodations, and psychological support. A comprehensive approach addresses both physical function and quality of life considerations throughout childhood and adolescence. We've covered the essential aspects of Erb's palsy in children, from clinical presentation and examination to management and long-term outcomes. Remember that early recognition, prompt initiation of physical therapy, and appropriate referral for surgical consideration when indicated are key to optimizing outcomes. Thank you for joining this pediatric case review session. If you found this information valuable, please subscribe to our channel for more educational content on pediatric conditions. If you have any questions, please leave them in the comments section below. Until next time.